Hello, good morning. Let me, as I get my slides in order here, thank Golan profusely for the honor of being here with you today. It is a great honor. I do love Israel. It's my second time here. I hope it's not my last. And really delighted to be here with you all today. I'd like to also say a word or two about Sidney Blatt. Golan mentioned that we collaborated together through him. That was my only encounter with Dr. Blatt. I never met him personally. That's common these days, I guess, where you get to know somebody over email and that's it. But I can attest to a couple things. One, he'd be real proud of Golan, no question about that. Number two, he was an inspiration to generations of psychologists trying to live up to that role model of generosity combined with intellectual accomplishment. It's really quite inspiring and worth trying to aspire to. And I certainly find myself doing that in his memory and in his honor. Okay. So with that, I just want to add that any association between Dr. Blatt and my name is completely to my honor, and I just really appreciate the opportunity to speak here. My email address is up there. Should you have a question that you don't get to ask me, or should you wish to obtain a PDF kind of journal article kind of thing of some of the things I'm about to touch on, feel free to do that. I'm going to introduce to you the model of suicidal behavior that I've developed over the years. And as a way to introduce you to it, I want to show you a video. Just a word about these videos. Number one, there are people who are in crisis and who are struggling and who deserve our respect and sympathy. Even this fellow, to a degree, though this is the least respectable of the people I'll show you, given what he has just perpetrated. But even he, I think, deserves a modicum of decorum and respect. I'm showing these videos because they illustrate ideas that are just very difficult to illustrate as vividly as this. And so that's the point. In these videos, nobody's going to get hurt, much less killed. So just keep that in mind. Though there are some dramatic moments. I'm going to show you this guy for about 30 seconds. He's going to be talking. He's got a video camera in his hand. He's videotaping himself out in the woods in the Pacific Northwest of the United States. And I just want you to listen to his words and make a couple of observations about him, because although you may not notice it at first, there's something extremely peculiar about this individual, in addition to what he has just perpetrated, which I will tell you about in a moment. So let me blow that up.
Getting to the point where just trying to live and pay bills and live as a civilian and go to work, it just freaks me out. It's actually more comfortable for me to think about living out here, robbing banks, pharmacies, just taking what I want for as long as I can. At least it'll be exciting. It won't be boring. And I don't have to worry about Lynette or Kayleen.
No, stop it there. That was 30 seconds of behavioral data. Lynette and Kayleen, incidentally, are his deceased wife and daughter, whom he has murdered within the past few hours as part of his murder-suicide. He is soon to go on to enact his own death within hours of this video. Anybody catch the behavioral sign that is extremely peculiar in this example? Nobody wants to take a risk and blurt it out and be wrong, maybe? There you go. Blurted it out and got it right. This is blink rate. And I'm going to, if the video will cooperate with me, show that again, not all of it, but just about 10 seconds, and watch
getting to the point where just trying to live and pay bills and live as a civilian and go to work, it just freaks me out. It's actually more comfortable for me to think about living out here, robbing banks, pharmacies, just taking what I want for as long as I can.
You know, when you first see that, it doesn't necessarily jump right out at you, but when you look for it, it's odd. That's very peculiar to have a blink rate of that nature. Basically, he didn't blink within that 20 to 30 second clip. The normal average blink rate is about once every 3 to 4 seconds. His is like once a minute, so it's extremely abnormal and very peculiar. Why am I making a big deal of it? Maybe it's just him. Or maybe it has nothing to do with the violence that he's already perpetrated and that he's going to continue to perpetrate. Maybe it's just a random connection. Maybe he's on some sort of drug that slows his blink rate. You know, you got to rule out all that kind of stuff. So we did that. This is a behavioral sign that is characteristic of the moments and the minutes before a human does something that meets the following criteria: daunting, difficult, fearsome, requires resolve and concentration. That's what people look like when they're about to give a piano concert. They don't blink much. They're focused. They're wooden in their expression because they're about to do something daunting and fearsome, and it requires resolve and focus. When you're about to box somebody for the world championship, that's what you look like. And when you're about to kill yourself, that's what you look like, because death by suicide, despite all of its differences from those things like boxing or concert piano, despite all those differences, suicide's daunting, and it's fearsome, and it requires intent, and it requires concentration and resolve. And because of all those things, you can't do it unless you get into a state like this where you're focused and able to confront and stare down the deep-seated fear that will confront you should you try to end your own life, no matter what the method and no matter what the means. It's a very instinctually fearsome thing to do. I'm not going to claim that it's courageous in any sense. I don't believe that. But I do believe it takes fearlessness. It takes a fearlessness of the physical toll and of death itself to be able to enact one's own death. We're going to see examples later in the presentation of people who desperately want to die. There's no question of that. They desperately want to, and they've taken all conceivable measures to enact that outcome, and yet, at the very last moment, they flinch. They blink, and it saves them. The people who we lose have learned somehow or another not to blink, not to flinch. And that's been a big point of this theoretical model that I'm going to share with you is how in the world do people work up to that state, to get to that very unnatural state to where they can ignore the extremely strong self-preservation instinct that's in us all creatures across eons and eons and eons of evolution have that deep within their bones, within their cells, and within their souls. This is a visual summary of the ideas that I want to delve into this morning with you. It's a simplification, but it's a useful simplification. I've just been talking about this part right here where it reads, those who are capable of suicide. An even better way to think about that is the term fearlessness. Fearlessness specifically of physical pain, physical injury, and death itself. That's what I mean when I'm talking about that right side of the image. Capability for suicide equates to fearlessness of physical ordeal. Incidentally, that's a very admirable quality when it comes to law enforcement officers, military personnel, firefighters. You need to do those things and do those things well. You got to be a little bit of fearless of your body. So it can be quite admirable. But when you combine it with the other things I'm about to talk about, that admirable quality transforms into something sad and deadly, no longer particularly admirable. What are those other things? They're listed on the left side of the image, and they have to do with interpersonal states of mind. One's called perceived burdensomeness, where you think that your life is a burden, it's a detriment to everybody else who would be better off if you were to take your own life. You really think that about yourself. And you don't know that you're mistaken. That's the tragedy here, is they've got something in their heads that's wrong. They don't know it's wrong. They think it's true, that everybody else will be better off, and they take their lives based on it. Other piece here is called thwarted belongingness, and basically that's easy to understand. Loneliness, social disconnection is what we're talking about there. Now, if you get those two states of mind in your head, and if they're severe enough and chronic enough, the idea here is that you'll develop a very genuine desire for death. But no matter how genuine that is, no matter how severe that is, it's not sufficient. Can't act on it. Too fearsome to do unless you've developed the sufficient fearlessness to act on that. So that's why we only lose those who are right in the middle here, who have that fearlessness of death, but it's been combined with the desire elements. I mentioned a moment ago that this is a simplification. It is of this. This is the actual schematic of the model. It pretty much boils down, though, to what I showed you a moment ago. I do want to just kind of point out that around the periphery, you get a lot more detail here. We make specific predictions about what are the ingredients of thwarted belongingness. Like, for instance, in our answers right here, it's loneliness combined with a lack of reciprocal care. What's perceived burdensomeness? What are its pieces? We think there are two main pieces to it, and they're listed right here. Self-hate combined with the sense of liability on others. I'm sure it's been obvious to you here for a minute or two at least of the resonances between what Dr. Blatt talked about and some of what I'm talking about up here. That's not, just by coincidence. He had an influence, like I said already, on generations of academic psychologists. I do want to point out this right here, hopelessness, which a lot of people think is implicated in the suicidal process, and we agree. We just think that you got to be hopeless about something very specific. Specifically, you got to be hopeless about these two states right here, ever changing. And if you get hopeless about that, you'll develop a desire to die, but you won't be able to act on it unless you also develop the requisite fearlessness. Let me show you an example of what I mean by this fearlessness idea. Now, we're just going to see somebody interviewed here. He's talking about self-injury. Not really talking about death. He doesn't want to die. He wants to injure himself, and he does so very frequently. Not to die, for other reasons which he'll talk about. This guy has that quality that I'm talking about. He's unafraid of physical harm an ordeal. He doesn't care about it.
Yes, I have, and I've cut myself a lot, and I've ingested things like bed hooks. One time a cassette Walkman down at Lucasville, breaking it up and swallowing it piece by piece. And, like I said, bed hooks, razor blades, ink pens, pencils, toothbrushes. October of last year at Lucasville, I ingested 4 ounces of, Magic Shave is what it's called, powdered Magic Shave. It's like Nair, but it's in powder forms for men, beard remover, hair remover, with 10 ink pens and a paper clip. And I still have, the last x-ray I think showed 5 ink pens in the paper clip.
How does one swallow? Is it a radio, or what is it that you swallowed?
I swallowed a cassette Walkman AM/FM radio and just crushed it up in chunks and slivers and just bend my head back and push it down my throat and then immediately drink water and swallow it down.
And why are you doing that?
I do that for many reasons. Sometimes the reasons are I'm depressed or I'm stressed, or, also just to, what I call pull a move to, go to OSU or Oakwood just to get out of this environment, the ignorance and, the what I call the animalisticality of all this, just the hell of it. I get tired of it, need a break. And OSU and Oakwood, the staff and COs and mental health, they're different, they're real. I would say that they're human beings.
And Oakwood is more like a hospital setting?
Yes, Oakwood is a mental hospital for prisoners that are in prison. So. And
is that a relief to get out of prison?
Yes, just to get out of this environment, get away from it for a while.
And so you consciously do that, or is it part of your illness? Or explain to me what that is.
I consciously do this, and it's a part of my illness. I know and understand that I don't have to do this, that I can control this if I, want to, and it's not that I am stupid or to the point that I can. It's just I don't care. When I get stuck in a thought, I go all the way with it, and I and I don't care of the consequences that I'll suffer or I'll cause other people to suffer.
So he's an exemplar, we believe, of this quality right here on the right side of this image. You wouldn't say this individual, I don't think, is at the moment that he was interviewed, he's not suicidal. Hurts himself all the time. And he only told you about 10% of his repertoire, more or less. It's incredible. But he's not doing it to die. He don't want to. He wants to manage, like he said, actually. He wants to manage his own feelings, and he wants to manage his own environment. But should he develop the states of mind on the left side of this image, you got a dangerous situation on your hand with somebody who has, he definitely has the wherewithal to act on any genuine suicidal impulse or urge that may come up. Impulse is the wrong word, actually, as I'll get to. I'm not going to focus very much on our empirical work here today, which is a little bit ironic, given that it's sort of the whole reason professionally for my being. But I did want to show that we're doing our due diligence on this. These are journals that, if you're in the field, you understand it's an ordeal to deal with these journals. And we've done our due diligence on it, and I just wanted to point that out. Again, if there are PDF versions of this that you'd like to see, I'm happy to email them to you. And I did want to mention that we have a new statement of the theory coming out in Psychological Review, which is the biggest ordeal of all of these journals, but a very elite outlet for theoretical statements. And basically this last paper here is a merging of the interpersonal theory of suicidal behavior in context of evolutionary biology. That's the point of it. If you're interested in that, I can get into it a little bit more maybe during question and answer. One thing about a novel model, and we think this is a novel, incremental beyond past theories, this model we think is, especially on the right side of it, but also on the left. One thing that you see about incremental novel models if they're holding their weight at all, they tend to do this. They produce predictions that you wouldn't have even thought of had it not been for the model. This just wouldn't even occur to you that veterinarians, for instance, who have a lot of experience euthanizing animals, some of them do anyway, and then actually others of them have less experience with that, you wouldn't predict that would relate to anything suicidal necessarily if you didn't know about these ideas, but they do, where the euthanizers have a lot more fearlessness of death. And I would predict, although we hadn't been able to get our hands on the data yet, that they would have higher death rates by suicide than the non-euthanizer veterinarians. My student Tracy Whitty led that work. Auburn just promoted and tenured Tracy, which was a good decision. I'm going to skip over some of these things. Here's another one. Anorexia nervosa is a very deadly illness, which you may have already known, but you may not have known the reason why it's deadly. 9 out of 10 deaths in anorexia nervosa are from conventional death by suicide. They're not from the consequences of self-starvation. That happens. 1 out of 10 deaths are like that. 9 out of 10 deaths are conventional deaths by suicide. Very strong link between anorexia nervosa and death by suicide. You wouldn't have expected that probably, maybe, but it's true. And you wouldn't have ever have thought, well, the reasons for it is because the illness involves doing physically harsh things. We've shown in a bunch of ways, including the work led by my former student April Smith, that hard exercise increases risk for suicidal behavior. When I say hard exercise, I'm not talking about running 10 miles every day. That's not hard compared to what these women do. It's almost all women. For example, we got a marathon runner, daily marathon runner, who keeps doing it despite her broken foot. That's hard exercise. That's kind of stuff that these people are doing, and it makes them just completely carefree when it comes to harming their bodies. Doesn't faze them as it does the most of the rest of us. Here's another prediction that you might not have thought of. Let me actually blink that out. No, that doesn't work. Okay. I'll leave it there for a second, come back to that. I want to talk for a moment about the role of alcohol. And I want to do it in two ways. One, I want to focus on the time frame right before death. So we're talking about the minutes and the hours before death. What are people's drinking behavior? That's number one. Number two, how about the months and the years leading up to death by suicide? What's their drinking behavior in that time frame? Crucial to distinguish those two time frames because the answer's different. I'll give you the quick answer and then I'll expand a little bit. Years, decades before death by suicide, you got tons of problematic drinkers in that group. Tons of it. Almost all of the decedents have a complicated long-term history with the misuse of something, alcohol or some other drug. It's a very powerful predictor in that time frame. So that's the long term. In the short term, they're all sober. At the time of death, they're all sober. Not all of them, but almost all of them aren't drinking. And some of them who have been drinking hard for decades stop drinking 3-4 days before their death, and their blood alcohol content at autopsy is 0.00%. Nothing in their system. You wouldn't have predicted that pattern unless you understood death by suicide is difficult to do. It's daunting and it's fearsome. And if you're really intoxicated, you can't do anything very well that's hard. You can't write a novel. You can't do a piano concert. Can't win a boxing championship. And you can't do this either because it's hard. Sober people do it much better than others, alas. So here's the data that I wanted to show you, and it makes the point I just made. And just to orient you a little bit, you got numbers of decedents here, and across here you got a metric of blood alcohol content. These are all people who have been killed either by themselves or by someone else. Black bars, suicide; white bars, homicide victims. And then you just see what the deal is with alcohol concentrations at the time of death. See that big black bar to the left? Those are the numbers. That's all the suicide decedents, and almost all of them have no alcohol at all in their systems at the time of suicide. Even though long-term, tons of misuse, tons of it. That's an important distinction, actually. Now, you got some. Here's one. The legal limit in the United States, not sure what it is here in Israel, but in the United States, it's right in here, just to give you a sense for driving. So you got a couple that are more intoxicated than that, but it's very rare. Much more common, actually, in the people who have been killed by others to have that much alcohol system in their system. Now, you might notice from reading the title of this that it's just one study. It's on one method, one country, one time frame. Might just be specific to that, but it's not. We meta-analyzed this entire literature. We got over 200,000 people in our database. All had killed themselves. All had had their blood alcohol concentrations assayed at the time of death, and it looks like this. You can just put that graph right on top of this one. It's the same graph. So I got into that because a good model will produce new insights that you wouldn't maybe even have thought of if it weren't for the model in the first place. We think our model has this characteristic or this quality. Let me show you an example. The Bridge is a documentary on death by suicide from the Golden Gate Bridge in California. It's pretty fascinating. What these filmmakers did was they stationed zoom camera lenses across from the bridge. They were maybe 500 yards away from it. And they just trained their cameras on the bridge every day for a year, during which they captured 24 people jumping to their deaths. Sounds terrible, but they also called the police every time they thought somebody was going to jump. And they quickly learned they had no idea who was who. They couldn't do it. In fact, we'll see this in a minute. I'll show you how hard this is to do. Speaking of the Golden Gate, let me give you just one anecdote that's kind of thought-provoking. And it's of the 1 or 2% of people who manage to survive this. They all report the following mental sequence. Almost all of them. Something along these lines. Totally willing to die. Totally fearless about jumping. Jumped without hesitation and with relish. Glad for it to be all over with. By the way, it takes 4 seconds to hit the water. 1 second in, same idea. 2 seconds in, same idea. 3 seconds in, things change. A gripping fear of death overtakes them. Nothing like they've ever experienced in the fear domain before. 1 second before their impact, which almost certainly will kill them. Ponder that for a moment. Everyone else who perishes at the bridge goes through those same steps, probably. Pretty tragic. Even someone as fearless as that, even in them, it kicks in. That's how strong this self-preservation instinct is. Kicks in too late for them, but it kicks in. That's how hard it is to overcome. Nobody's going to jump to their death in this footage. But now I want you to try to point out who is the suicidal person here. Because that's what the filmmakers were trying to do when they called the police. Is it her? probably not there to jump to his death, although the filmmakers saw people who were doing things like this jump to their death. So even there, you don't know. What happens here is that this guy is a good Samaritan. He's going to be a rescuer of that first girl that was in that sequence. She's the one that ends up one step away from her near certain death, and he's going to rescue her. What I want you to focus on when I get there, two things. How hard does she fight for her death? That's number one. And number two, does she aid in her own rescue? Specifically, watch her legs. So I'll play it now. Now here's the struggle, such as it is, for death. She's fighting him a little bit, but I've seen harder fights. And now watch her legs kick in right here. She's resisting a little bit. In fact, he's just going to pull her right over. There she goes. And this rescuer, he sits on her on the other side of the railing until the authorities come and take over. I've got a lot of videos of this sort where people are bad Samaritans. This guy's a good Samaritan. The bad Samaritans just walk by. There's a bunch of them. Then there's a good Samaritan who does stuff like this. It's really kind of positive and redeeming. There's some reaction to this kind of footage sometimes. Well, she wasn't serious, maybe. Or maybe she's just doing this on an impulse. Listen, you can't get to where she got on an impulse. That took thought. That took planning. That took intent. And if you think she's not serious, take a look at that height from the safe side of the railing. It's daunting. She's on the bad side of it, one step from a very miserable death. That's the other thing that people don't understand about this. Not instant. Death's not instant here. This is a miserable, horrible death. She's one step away from it. I would say she was serious. Can't understand her behavior very well, I don't think, unless you incorporate the role of fear. All right, let me talk about this other side of the model a little bit. I want to talk about the thwarted belongingness piece, and I want to go back in history a little bit to the United States context in September of 2001. And let's focus on 3 days in September of 2001, the 9th, the 10th, and the 11th. The 9th was a Sunday. 92 of my countrymen jumped to their deaths or otherwise died by suicide on that day. 92. That's how many we lose every day in the United States. More than that, actually. Monday, September 10th, 98 died by suicide in the United States on that one day. Monday, by the way, is always higher than Sunday. It's not a joke. It's a true thing. Monday is the weekly peak, week in and week out. Monday and Tuesday is the peak, and then all the other days trail off, and then Monday's a peak again. Oh, thank you. September 11th, 2001, in the United States. 36 in that vast country of 300 million people, 36 people. The lowest daily toll ever in the history of the country occurred on that day. You might be bringing to mind the people who jumped to their deaths from the towers. Those were murders. The New York City Medical Examiner officially classified those as homicides. Those don't count. Those people were murdered by the guys that slammed those planes into our buildings. Why is it that on a day of national tragedy and mourning and fear, did suicide rates plummet? Why didn't they go up? We think it's because people pulled together around a national cause. And when that happens, suicide rates go down. And when the opposite process happens, they go up. I'll give you a less weighty example. Again, in the U.S. context. Pardon me for my provincialism. And my love of sports. Because this is a gleaming moment in American Winter Olympic sports history where the U.S. hockey team beat the Soviets on February 22nd, 1980, a day that we now call the Miracle on Ice. Because it was a miracle. Back then, the rules were such that our NHL guys, the professional, we couldn't play. They're professional. That wasn't true for the Soviets. So it wasn't fair. It shouldn't have ever happened. The geopolitical context could not have been more tense. Look at that, 1980, teeth of the Cold War. Our hostages are still in Iran. The Soviets are just into Afghanistan. Just a sporting event, I guess, but not really. It was a lot more than that. I can tell you, I remember where I was on that day. We asked, did suicide rates in the U.S. go down on that day as compared to all the other February 22nds that we have on record? And the answer is yes. It's right there. That's the Miracle on Ice. So this is the number of daily suicides. And then across the bottom, you got February 22nd of different years in the 70s and 80s. But same thing happens if you expand it out. Never been a February 22nd before or since with fewer than 60 suicides, except on the day of the Miracle on Ice. Notice the difference between this and 9/11. This is a day of national celebration. Pull together around that, suicide rates go down. 9/11, a day of national tragedy and fear. Doesn't matter, pull together around that, suicide rates go down. Pulling together decreases suicide rates. Doesn't matter what the reason is. I told you about the weekly variation on day of the week, with Monday and Tuesday being the peak. That's summarized here. By the way, there's another source of systematic variation with regard to month of the year. It peaks in the summer, in the spring and the summer. It doesn't peak around the winter holidays, which everyone gets wrong in the United States. That's the low point, actually. That's when we have the fewest deaths by suicide, or November, December, and January, around our winter holidays. Why? Because people are pulling together with their families around the holidays. Then comes April, May, June, July. You get people with more energy, more focus, more resolve, all the kind of things you need to do anything that's fearsome and daunting, including death by suicide. Incidentally, that's completely 6 months shifted in the southern hemisphere, as it should be if it has to do with the onset of spring. And it is. That's the pattern in the southern hemisphere, 6 months shifted. Their peak is right now. They're going through their suicide peak right now because it's summer down there. Ours is in the spring and summer, but 6 months shifted from theirs, of course. All right. One last example. This actually happened here in your country. It was on the local news, and I'm sorry if this happens to somehow coincidentally hit a nerve personally, but there's no name here. There's no identifying information. What we're going to see is a near miss at the train tracks. And it's an extremely dramatic one. I've paused it here. It's very grainy. Again, let me remind you, nobody gets hurt, much less killed, in any of these videos. This woman was admitted to inpatient psychiatry 9 days before this incident. And she was admitted because of a plan to go to these same tracks, kneel before an oncoming train, and thereby cause her own death. That was her reason for admission. She got a lot better in the hospital, a lot better, genuinely better. Lost her intent to die. They discharged her, And I don't know if they followed up on her well or not, but I doubt it. Because, as regularly happens, even in people who respond well in the hospital, within hours she's back in that same spot. Suicides, spike right back up. And she's back there again. And this time she follows through with her plan, except at the last moment, her body takes over and saves her. Now, think about the ideas that I've been sharing with you this morning. Does she genuinely desire her death? Is she fearless enough about a very fearsome thing to place herself between tracks and face a rushing, oncoming, tons and tons of steel going about 100 miles per hour? The answer to all that's yes. Even so, at the last moment, she's saved. Let me give you a little clue about this because it's hard to see. She's going to kneel between the tracks. The train's coming on the right set of tracks from top to bottom. If you kneel, the physical motion of kneeling, it takes your gaze, your vision. It'll take your vision down to where you're kneeling, and then your head will pop back up. And that's what happens to her. She kneels, she looks down to where she kneels, and then her head pops back up, and then her body kicks in and saves her. So there she is. She's kneeling, looks up, throws herself on her back. It's a long train. She's under there the whole time. And there's not a scratch on her. She's psychologically stunned, of course. But physically, she's completely unharmed. These are examples, I think, of how you can't understand this domain of behavior without an emphasis on fear and fearlessness. And then when you combine them with these other ideas, you get a dangerous situation. You also get a parsimonious account of a phenomenon that kills way, way too many people. I haven't said much about perceived burdensomeness. And maybe I'll just leave it at that, other than to say both it and thwarted belongingness are very promising, clear targets for psychotherapeutics. Psychotherapeutics, by the way, of any sort. Golan had a slide up listing different approaches to the treatment of depression. Those all can have targets. You're using the therapy to target this thought or this feeling. These are the targets that we suggest you target with those therapies in suicidal people. The theory is a three-factor theory, and you might respond. Suicide decedents, as a group, are as different as we all are here today. Some are old, some are young. Some are men, some are women. Some have one psychiatric condition, some have another, etc., etc., etc. And that's all true. The number of distal risk factors for suicidal behavior is in the hundreds. We are not saying that those are not risk factors. They are. What we are saying is that the one commonality that diversity shares are these three factors. We think people with schizophrenia who die by suicide do so because they travel through the same pathway as does somebody with major depressive disorder who dies by suicide, or anorexia nervosa who dies by suicide. It's a final common pathway model. That's our claim here, is that this is the universal final common pathway through which all suicide decedents travel. That's a tall claim right there, by the way. Big conjecture. Ambitious one. I'm not doing it out of a lack of humility. I'm doing it out of a philosophy of science that says, make big claims and then see if somebody can refute it. Learn from that and then make some more claims and then keep doing that. And you'll figure something out sooner or later. That's at least my philosophy of this. I wanted to talk briefly about clinical work with suicidal patients. This is a photo of the novelist Malcolm Lowry. He died by his own hand within hours of this photograph. I show it for a couple reasons. One is just the pretty clear sense of postural resignation. You might say hopelessness, but I'm not really showing it for that. It's more the look on his face. I think this is an example of the bemusement, the detachment, and the 1,000-yard stare that you can see in people in the minutes and hours before they do something like this. Here's another angle on that same facial expression. Now, typically you hear about the 1,000-yard stare. You know what that is? It's like a remoteness, like a remote look off into the distance, typically associated with PTSD. And it is associated with PTSD. We think it's also associated with suicide risk. And you might notice one other thing, by the way, about this image, which is right there. Very distended liver, probably, because of his decades of epic abuse of alcohol. Epic. I've never heard of a case of a person who could drink as much as this man for decades, every single day, without exception, except for the day or two before his death by suicide, at which time he had no alcohol in his system at all. A little more on clinical assessment and management of suicidal behavior. I mentioned the targets for therapeutics, and I only mentioned 2 out of the 3 factors because we think those are the only 2 that are modifiable. We don't think the fearlessness piece is modifiable. We think once it's there, it's there. Part of that might be because it's about 2/3 genetic. Two-thirds of the variance in that characteristic is genetic. Not that genetic things are necessarily unchangeable, they're not. But this one we think is kind of unmovable clinically. And if you think of yourself, if you have some of this in you, or if you know somebody who is like a daredevil, fearless kind of character, are they going to change that? Probably not. That's who they are. That's kind of in them. But these other 2 things are modifiable. Well, we think that means with regard to assessment, you got to focus on all 3. Because you want to know who's who. Once you know who's who, then you switch over to modification of risk. And there the targets are twofold: burdensomeness and belongingness. We haven't made this claim yet, but you could based on the logic. And the claim would be, clinically, this is all you need to know to manage a suicidal patient. We're not there yet, though. We think there's other things that you should keep your eye on. And here's a list of the top 5. This is a very busy slide, but I'll give you some time to look at, and also I'll walk you through it. 5 risk factors and their modification strategies that are the consensus top 5 in the field in terms of imminent risk for suicidal behavior. Starting with number 1, talking about or planning suicide. You might think that's too obvious even to be mentioned. People overlook it all the time. I can guarantee you that. It's a very clear predictor of what somebody's about to do. When somebody's about to do something, and they say they're about to do something. I took a trip to Israel. I told my mom, I told my friends, I'm going to Israel. And I did it. That's how it usually works. And it would be odd, by the way, if my friend said, oh, he's not really going to go. He's just talking about going to Israel. He's not really going to do it. That would be peculiar if they said that. That's what people say about suicide. He's not going to really do it. Gets dismissed a lot. That's peculiar. When people intend to do something, they tend to articulate it. Now, 70% are like that. of the deaths by suicide, 70% say they're going to do it, leaving 3 out of 10 who don't say anything. So it happens that people act out of the blue, but it's rare. The others are agitation, insomnia, nightmares, and social withdrawal. You see that combination clinically, especially in somebody who's fearless, who thinks they're a burden, and who's hopelessly alienated from others. That person needs to be managed acutely. In the hospital probably, but if not, acutely. And the management strategies are listed there. Some of them will be clear. Others will be a little bit cryptic to you. I can send you this slide by email so that we can follow up on it and discuss things. I'm getting a little sensitive about time. I don't want to overstay my welcome. Turn back around to blink rate. I started with that because I do think it's a potential behavioral marker of this fearlessness, aroused state that we think is a necessary component of suicidal behavior. And I just wanted to remind you of it, along with the 1,000-yard stare, and along with insomnia, agitation, nightmares, and the others. Get a good handle on that. Clinically, you have a good sense of who's at risk and who's not. And you have targets. Targets to shoot for clinically and psychotherapeutically about what to try to mitigate. Let me just close with saying yet again how much I appreciate being associated with the memory of Sidney Blatt. Thank you for having me.